Good morning, everyone. Thank you for joining us. We're going to let a few more people join before we start the webinar. So just be patient with us as we allow people to filter into the room. Thank you. All right. Good morning, everyone. Thank you so much for joining us for this version of Africa Calls, which will focus on pathology. As you know, ASCP is hosting a series of 4 different teleconferences or webinars. The Africa Calls series, which are both cytology, which is led by Leslie Lomo and Ali Lowe in collaboration with the American Society for Cytopathology, as well as the Africa Calls Pathology, which is run by ASCP. And in the Africa Calls version, we will have a primary presentation for usually 30, maybe 40 minutes with some discussion and Q&A. The other series that we have is the Echoes, where we have the Pathologist Echo, which some of you have attended before, where we have a short didactic and 2 case presentations. And we're also adding an echo for cytology that will also be led by Dr. Lomo and Dr. Lowe, where we'll have a small didactic on cytology. And that will be followed by 2 case presentations on cytology. So thank you all so much for joining us today. I'm very excited for this first session to have Dr. Ishetu Lima, who's from Ethiopia, who's an ASCP member volunteer in Ethiopia and has been working with us for many years, talking to us about African pathology laboratory networking. And I will turn it over to him. He's going to talk for probably 20-30 minutes. And then we want to have an open discussion. So the way that we will do the discussion, if you have a question that you want to ask of the audience or the panelists, or just a question in general, use the Q&A function at the bottom of the screen. If you want to just put in your thoughts on something, if you want to, write a couple of sentences about your thoughts on something that Ishetu or someone else has said, you can just put that in the chat. So we don't need to respond to it. We just will be able to capture your comments in the chat. So comments in the chat, questions in the Q&A, and we'll go from there. And this is being recorded. So for those who are not attending, they can listen to it and at their leisure in the future. So I will turn this over to Ishetu. Go ahead, Ishetu.
All right. Thank you, Dr. Dan, for giving me this opportunity. So do you hear me? Just to check.
Yes, we hear you just fine.
All right. Thank you. So my presentation today is on African Pathology Laboratory Network. So I'm just going to give you a brief why we need to really networking. We need to establish the networking in Africa. And so I will go through it directly. This is a brainstorming session, open discussion. It's not yet established, but we need to hear what your thoughts. So that's all. So what is actually the importance of establishing the African Pathology Laboratory Network? It's obvious that, usually we have a late diagnosis. This could be caused by several factors, including infrastructure, probably, especially in Africa, patients come at advanced stage, and then we don't have also adequate number of pathologists, and service by itself is not really accessible. So, and at the same time, we have a very poor infrastructure, especially in pathology sector. We know that the clinical pathology relatively better as compared to the anatomic pathology service. And then we have also no basic and specialized pathology lab service available in all African countries actually. And we have also no second and third level pathology diagnosis consultation programs in some part of the Africa. And of course, we need also to improve a long-term around time for this diagnosis purpose. No external assurance program, which is not really well organized. We know that there is a program with CDC and others for especially for purely clinical diagnostic laboratories, which is very good. But in case of pathology, we have also some shortage or some problems. And we don't have right now, as maybe I may, maybe somewhere it might be, but as far as I know, there is no well-organized network regarding the African pathology laboratories. So how we are going to approach the problems? So I just thinking, yeah, we need to design a platform that pathologists actually interact each other and share experience in the African continent. And then so we have could be the APLN could be an ideal place to help patients in Africa through digital platform by connecting African pathology labs. Sorry. So a basic lab connect to, so the idea is like from the high level mapping, probably you will have like local basic pathology lab, which could be private or public. And now after that in a country, we have also sometimes you might have local specialized pathology lab, and then that will be also connected with regional specialized lab. And then finally, we might have the headquarter of the African Pathology Laboratory Network. This is the way we go and connecting and formulating the network. So specialized lab connect to the referral specialized lab or APLA designated lab, which is going to establish and ensure that will ensure timely diagnosis, consultation, and advice, so the patient will be in a very good position to get the result timely and accurately, and also getting the second opinions. And AP helps to explore and developing and delivering innovative solutions and technologies. This one part of it. So how APL going to establish? Probably it will be the largest pathology professional advisor groups in Africa, as far as I'm just thinking. And a patient-focused approach will have it and provide high-quality professional experience sharing. We'll also consider in this platform, and also developing a quality assurance system, which is very pragmatic, not good as other sectors like diagnostic, purely clinical pathology, and sharing and distributing external quality materials using this platform is another idea why we established this network. And external assessment support. This is, I mean, probably we might think of internal and external auditors that going to around Africa to assess labs, especially pathology lab, to see where they are. And the other one is also advising on cost-effective testing strategies and policies we are expecting from this network, conducting consultative and workshop services, improve a turnaround for this purpose, promoting early medical interventions for preventions and treatment also. So the objective of this network will be reaching the millions of cancer patients, help them in diagnosis and treatment, and strengthening pathology lab network in Africa, introducing the second and third diagnostic consultation programs using this platform, and also strengthening and introducing also the quality assurance program for those participating in pathology labs in Africa, and advising on pathology diagnosis treatment. And also it gives us a platform for conducting some operational research, which is going to help for policy making of decisions at the end. So how this will be happen? So we are going to select the African selective African pathology labs will be formed a network at the beginning and identify which labs are providing basics and which one is advanced, and connecting the basic to specialized pathology lab. That will be a second phase, and select pathology labs that are designated as APLN, which is the higher hierarchy, and promotes also remote diagnostic service. And then of course, this is an idea but managed by the board of directors. It has own secretaries, so we have some kind of structure, organizational structure will become. So just as how we are going to start now, I assume that as a pilot project, the APLS process going like this one. The first one is select specialist lab that has actually whole slide imaging, telepathology technology in each country. And we need to simply, as a pilot, we can select two specialized pathology lab per country. For example, one in private, one in public, one private. It might be, I mean, the combination could be different based on the country nature. For example, in Ethiopia, probably you can have one hospital for public, one from the private, like we have recently very giant pathology service coming to add this also, and on board, they are on board actually. So we can also think of different combinations. And we need to also select a basic path lab, national level. This is the first one. Those who are willing to be part of this network and able to send samples and slide to country level specialized pathology lab for the processing and also for slide digitalization purpose. They are also willing and are part of this. And as those specialized pathology lab send images to the APLN designated path lab for the second or third level opinions. And pathologists now ready to diagnose or report cases remotely, which is really the whole idea. So this is probably a pilot project. And the second project as a pilot again regarding the external quality assurance program, external quality assurance programs including proficiency test, rechecking of samples and assessment. So by sharing and distributing external quality materials to those participating in this network will be an advantage. So probably we can think of selecting the best labs that characterize slide image or a blind slide rechecking program who are going to be developed this one, sharing to the Africans network. That's an idea. And then we will have also some data analysis reporting, providing feedback to the lab. We are there, what are the next corrective action, blah, blah. So we need to also consider, and then we might have also monitoring and evaluation program. So using this as a startup, we can think of that. And so now the step to be followed. So probably we need to have the APLA project coordinator, and we need to select the headquarters for this specific program, and forming a committee and a groups, and also selecting project representative in each country with a focal person to do this, and discuss how to form a pen establishment, and discuss the scope and the purpose of network, and also circulating some draft document for review and feedback, so that based on that we just reach up, just conclude, and then bringing some tangible document how this network is going to work. And then we need to also develop a website. I mean, the socializing is also very important in approaching, and potential donor for us, at least for startup, is also one idea that has to be discussed. And membership fee as institutional member, this could be possibility to some source of fund for this project. So some of the business modeling, how we are going to approach this one, since this program will not be purely profit making. We are probably, it is not purely profit making organization, but we need to have some funds to run operational purpose also. So I'm just put some highlight how we gonna work on this. So the first one could be out-of-pocket modality, which is a minimal cost per patient for whole slide scanning purpose. Of course, it depends on the willingness to pay for these programs. Payment will be received by specialized pathology lab account labeled, and some of the payments could be transferred to LP and designated lab for service render. And the second approach would be a donor modality, approaching international, regional, and local funds to support these projects like ACP, SLM, Africa, CDC, CDC of Atlanta, WHO, and other could be also one of the areas that to get think of it. And the other one is we know that in each country probably they will have some association, pathology association. So as part of social responsibility, we might approach association to just cost sharing program, to be part of a cost sharing program for this specific program. And then the other one is for grant or research fund. So this network could also compute and enter to international research grant when they are actually available. So from my end, I think this is some of my thought. So finally, I really acknowledge Dr. Miller, Dan, and ASCP team as whole. Thank you, Dr. Dan. Back to you.
Thanks so much, Shatu, for this presentation. So I think we can open it up now to comments from the participants on the call. We have about 25 people, which is nice, or questions. And I just wanted to make some general comments on this while you're thinking about your questions or putting your comments in the chat box. So number one of the major challenges I think that we've encountered in all of the labs that we've worked with, and there probably are exceptions in South Africa because of the level of organization and commercial activity around healthcare in South Africa. But outside of South Africa, we've always encountered a challenge with external quality assurance. There's the market for external quality assurance programs in anatomic pathology, specifically, proficiency testing or unknowns or checkpoint studies, path studies, et cetera, where you can receive either a block or an unknown histology slide and you report it back out and someone grades you on that and tells you how you're doing and benchmarks you against your peers, et cetera. That is just really non-existent. We have found makeshift programs where, for example, I believe some of my colleagues in Nigeria or Ghana, I can't remember which one, were working with a group in the UK, and they would work together and send cases back and forth. And it was kind of EQA, but it was clunky and slow, and it was having to depend on external parties from outside of Africa. And what we really want to see, I think, for this to be sustainable is the idea of either in-country regional EQA. For example, I'll just give you some examples so you can understand how I'm describing it. So in Rwanda, for example, Rwanda has a national reference laboratory, which is run by the Rwanda Biomedical Center. And the National Reference Laboratory does not do histology, but they are the laboratory charged with quality assurance for the country. So they have the organizational structure, because they don't do pathology themselves, to oversee and monitor quality assurance material for all of the 4 or 5 labs in the country that do anatomic pathology. And so, for example, ASCP could support NRL, and this has been a plan prior to COVID. Unfortunately, COVID got in the way. ASCP could work with NRL to support them to set up the right approach logistically to collecting blocks locally from laboratories in Rwanda, vetting those blocks with external third parties using telepathology, and then reorganizing those blocks to then send them back out to other labs within Rwanda as quality assurance material. So you can imagine if the Rwanda Medical Center, Military Hospital sends NRL 10 blocks of 10 different tumors, 2 breast, 2 colon, 2 kidney, etc. And then NRL organizes those in such a way that they vet them with an external third party to make sure the diagnoses are accurate using telepathology, which they will be because RMH already uses telepathology, and then reorganizes them and sends them out to Butaro or Butare or Kigali University Teaching Hospital as unknowns, right? And so you're not sending RMH back the same sample, you're sending only RMH's samples to the other 3. And that same logic holds true if Shiashka sends cases or Butaro sends cases or Butari sends cases, you reorganize them and send them to the other 3. And that way you have a self-sustaining, very low cost way to do external quality assurance within country. Now, an alternative model is to do that regionally. So Kenya would collect blocks from their sites and vet those and make sure the diagnoses are correct. And they would share those with Tanzania, and Tanzania would do the opposite. Tanzania would collect blocks and share them with Kenya. And then the central labs in both places would send those out to their labs for the quality assurance piece. And what does that quality assurance look like? So you may receive a piece of tissue in a block, or you may receive a slide and you're asked to either cut and stain a slide, or you're asked to just stain the slide and review it. And you can report those results centrally back to the lab and get the scoring and the benchmarking. So that's how proficiency testing for anatomic pathology works in most places. The problem is it's extremely expensive. And so if we think about a laboratory network, as Ashetu has described, there are some unique opportunities to have external quality assurance at a very low cost. But then how do you cover the costs that are there? Well, the government labs, the laboratories that are part of the national laboratory system would be participating for free, and then private labs would now have an opportunity at a very low cost to pay a fee and also be able to participate. And that would be essentially enough money to run that program going forward. So that's an example of how this lab network that Ashetu is describing could create an opportunity for external quality assurance, which we simply don't have right now because of expense. A third alternative model, for example, is that South Africa could be very entrepreneurial and create GDP-paced systems for quality assurance, but then it puts a lot of pressure on South Africa and their tissue banks and their ability to create samples and get those out to labs, which have very different financial structure to try to make that work. And so we don't want to put that burden on them, but if we think about countrywide or regionalized versions, it can be very helpful. So we have some comments. So Louis from Burundi said the prerequisite is to develop good practice in histologic standard techniques for acquire good slides before embarking to whole slide imaging. That's absolutely correct, Louis. So when you are considering this laboratory network that Ashetu has described, you want to make sure that any labs that are participating have really high quality histology before they would go to whole slide imaging, because if you don't have high quality histology, the whole slide images are not going to be able to help you in sharing those cases with other people. So that's a very, very important concept. And then and also Louis says it's important to have good SOPs to improve internal quality and therefore before looking for external quality. And that's also true. So you wouldn't move to external quality assurance until you already had internal quality work in place. And that again can be achieved actually with after you get your histology in a good place, that can be achieved with whole slide imaging. So by having a third party that can look at your images, just digital images of your slides, they can give you really great feedback on getting your internal quality up to where it needs to be. And then you can move to a formal external quality assurance program. So then another anonymous attendee says, what alternatives could we think of to establish an APLN program in some African countries that do not have established path labs, both basic and national level? Yeah, that's a great question. So I think Ashetu's point, and I'll let him comment on this as well. Ashetu's point is about anatomic pathology, the histology aspects of it. I think for non-anatomic pathology labs, ASLM, the African Society of Laboratory Medicine, has done a lot of work in this area, and we continue to try to partner with them and work with them on these kinds of projects. So if you don't have histology in the country, or you don't have path labs available and you want to support the other labs, ASLM is there. If you want to have pathology labs, then I think you have to open up your conversation with, with ASCP and with other organizations that can help you establish your labs to get those going. Shetu, did you want to comment on that?
Yeah, perfect. I mean, for the basic labs, this SLM and others partners are actually working on it. And then for the last decade, internal and external quality assurance program has been deployed, and then relatively they are in a very good position as compared to the atomic pathology. Yeah.
Great. And then let's see who else we have. We have Louis with one more comment. Professional testing, proficiency testing is non-existent in my country for quality of slides. It is important to train the histotechnologists. Absolutely. And that's one of our one side goal of having a network like this, is that you can create external quality assurance programs and proficiency testing models that are very low cost, but are providing you with that quality that you need. George from Ethiopia says, it's a very good presentation and the idea works in Continental Network. I think there should be standard practice at laboratories in such practice, right? And I think so. So everyone on this call who works in a laboratory knows that SOPs exist, right? Standard operating procedures exist in laboratories. If you are working in a lab that doesn't have SOPs, as Louis was suggesting, that's where you start. You have to have your standard operating procedure in place. You have to know what you're supposed to do for every test before you do it. And for histology, the good news is it's a handful of SOPs across the tissue processing system. The bad news is there's a lot of variability in individual samples, right? So we can talk about grossing and processing and microtomy and sectioning, staining and making the slide and delivering it to the pathologist, for example. But if it's a colon biopsy versus a mastectomy sample, the grossing is extremely different. The processing is a little bit different because it's fatty tissue. So there's a lot of variability. And so it's not just having those SOPs, it's having them, everyone understanding them and understanding the variations that have to happen in that regard. Let's see what else we have. Dr. Baraket from Ethiopia says, what about the legal framework? For instance, in Ethiopia, the first draft has yet to be adopted. So any ideas on how this can move forward? That's a great question, Dr. Baraket. So I think when we think about networks, there are precedents for this outside of anatomic pathology. And so Miriam Schneidman from the World Bank has the East African Pathology Laboratory Network already established, has been established for many years, which is a cross-border network of laboratories fully vetted to protect against infectious disease epidemiological outbreaks, right? So the idea is that those labs are all connected to each other. They're on the borders of 6 or 7 different countries in East Africa, and they communicate constantly in order to make sure there aren't outbreaks happening and protect the borders from viral outbreaks, et cetera, But that framework that she's established is across, as I said, 6 or 7 countries. So having a conversation with her and the World Bank to say, how did you do this? How was it cross country, et cetera, I think will give us a good insight into how to do that from a legal perspective and how to move it forward. Ethiopia, as you know, being there is a little unique. And so Ethiopia also is 100 million people. So it may be that Ethiopia, sort of like Nigeria, would consider setting up an internalized sort of laboratory network with some connections to other countries, whereas other countries which have very different legal and connectivity approaches may be able to have more freely associated connections between the countries. But I think it's a good question, and there are precedents to look at for that. So Yawali Ilyasu from Nigeria says the establishment of telepathology in all participating countries is essential. And I absolutely agree. ASCP has done a lot of work in this area. We have more than 20 sites in 16 countries. Probably many of you who are on this call are in a lab that doesn't have an ASCP supported telepathology site, because there are just so many of you and we can only do so much. But we do know that people are replicating that model. We now have a spectrum of cost where you can set up telepathology for very low cost, less than $100, up to, what we would call the Cadillac version of what you would use in Africa, which costs about $45,000 to set it up. The good news about telepathology is that once you set it up, there's very, very, very low cost moving forward. It's essentially internet and electricity to keep it running. These devices are quite robust, but that initial capital cost can be a challenge. But once you have it, it allows you to do, north-south collaboration for research, south-south collaboration for telepathology and research, archiving, tumor boards, all kinds of things, in addition to getting secondary consultations. So I think it's really important that we think about that and how we can get all of our colleagues who are interested on that network as soon as possible. Louis also says, currently there is the East African Pathology Networking after the East African Health Project Network funded by the World Bank. Yeah, that's correct. That's the one I was talking about. So reaching out to Miriam with Eshetu's ideas and other people's comments, I think we can get some good precedent framework for how that works. And then Louis also asked, which person at ASLM is responsible for anatomic pathology? That's a great question. I believe that ASLM has it in their hearts. And if anybody is from ASLM or works closely with them and wants to comment, please do so in the Q&A or in the chat. They have it in their hearts to cover all lab services, but they are not the African Society of Anatomic and Clinical Pathology, right? They're the African Society of Laboratory Medicine. So they are doing what they can, but I think anatomic pathology is a lot, and they have not really taken it on as a formal program, except for maybe here and there webinars about cervical cancer and HPV testing, which there's some overlap. But I think having a conversation with them to say, is there bandwidth? Is this a program where they could get funding perhaps from CDC or CDC Africa to expand to pathology, anatomic pathology, and support all of you to build this network? I think that's a great question and something that we could reach out to them and discuss with them in general to see what they think. Okay. Ali Mutaz says, telepathology is a good idea for histology professionals. I believe it is the right time that ACP can lead, and especially through AfricaCalls and Pathology Echo, to form and make this network active for pathology. Thank you, Dan Center. Eshetu, thanks, Ali. So Eshetu, go ahead.
Yeah, I mean, one of the issues from the Dr. Barakat raised, the legal issue, that is probably the major problems. But I believe that especially in the whole slide in telepathology could not be, because we are not really transferring samples or material from one country to other country. That could be one way out to really to come up that problems. But because we believe that from the basic one, the basic pathology lab could transfer the specimen within the country for those who, like, for example, St. Paul have their whole slide image, so that we can create this platform so they can send their sample, they process it in the St. Paul, for example, and then they digitalize it, and then they send for the second opinions, and so it continue like that. We can actually probably can skip some of the legal issues just to say some reflection on that. Thank you, Dan.
Thanks. And then we have Tuadros Gibramariam from Ethiopia. The idea of starting regional quality assurance looks good, but it might be expensive. I'm from Ethiopia, developing country, so the government and private labs are not fully equipped. How would you mitigate such lack of infrastructure? So that's a great question. So as Eshetu referred to and Louis and Yawali reiterated, there are some basic tools that you need, or some advanced tools that you need for this to work really well, for this to be very efficient. But that doesn't mean you can't start from somewhere, right? And so, for example, and again, I'm just using this as an example because I don't know the answer for Ethiopia, but we can talk through that. In Uganda and in Rwanda, they both have existing specimen transport networks, right? So rather than relying on the post or some other courier service, the laboratory network themselves could courier the samples. So that cuts down on the cost right there, because that network, that courier is already happening. They're already moving materials from labs to the central lab and back already. So hooking up with those existing laboratory networks, and many countries have these because of all the PEPFAR work and the HIV sample transport that's happened, is one way to make that cost essentially zero, because you're just adding one more little bag of something to the truck that's going to the lab and picking up the information. The other is having electronic connectivity, regardless of whether or not you have telepathology. So if you have, as Eshetu referred to, a website, but for reporting results or reporting your unknowns back to the central lab, for example, if you have a computer-based interface that you can do that with, and those are fairly inexpensive to set up, there's a lot of open source software that allows you to do that. Then once you receive the sample, reporting it back is electronic and it's very easy. So the time of the staff is really where the cost comes in. And fortunately or unfortunately, quality assurance is seen, just as an example of how the lab network would work, quality assurance is seen as a, I won't say a necessary evil, but a necessary process that doesn't necessarily have an ROI per sample, right? You have to do it in order to be accredited. You have to do it in order to be, your results to be valid, but you don't get necessarily paid for doing quality assurance. Unfortunately, that's true in the US, true in Europe. It's obviously true in Africa. So I think there are ways to start without having full-fledged telepathology. But obviously, if a site has a whole site imaging system, then they can receive, a block from the courier system, cut it, stain it, scan it, report it back, and then share that image back with the lab, and then the central lab can say, yes, the quality of that slide looks good and you got the right answer. So that's the full quality assurance issue. But I do think each lab has to be considered. This is something we've learned over many years. Each laboratory has to be assessed to determine where they are in the process and what they need. And as Louis said, many labs will need SOPs and basic retraining in histology to make sure their quality is okay. And you wouldn't start doing quality assurance in that lab or telepathology without having them already up to speed for those SOPs, for example. So that individual assessment is important. And you're very lucky to address in Ethiopia to have Eshetu and George, who are ACP member volunteers, who go around to different labs and talk with them all the time about, what the challenges are, what your gaps are, et cetera, and how we can help you fill those gaps. So I would encourage you to reach out to Eshetu and George. And then TechnoSpark 4, I believe that's not a person, I think that's technology. The high cost and inaccessibility of immunohistochemistry compromise the consulting process. Any way out? Wonderful question. Thank you so much. So two things on this. One, I think Eshetu's idea of a laboratory network is right in the spirit of the challenge of immunohistochemistry. If you have a network that's countrywide or regionalized, you can share immunohistochemistry resources, right? So 10 labs can send their cases to one lab for immunohistochemistry work, and that reduces the cost for all 10 of those labs not having to set it up individually, and it reduces the cost for the one lab because they can buy their reagents in bulk. That's especially helpful for government labs or labs that have operating budgets that don't have capital budgets. Another approach is to work with a private lab and to work with your Ministry of Health on a voucher system, right? So you make the argument in very eloquently written documents and letters to your Ministry of Health that patients in government hospitals sometimes need immunohistochemistry for diagnosis and treatment, but they can't afford it. The lab can't afford to do it, but the private labs do it all the time. Can there be a voucher system where when a patient reports to a private lab with a block and a report from the government lab that says, please perform the immunohistochemistry, and the government will reimburse you a fraction of what you would get paid, but it's helping the patient, it's helping do that. And we know that there's precedent for this. Several private labs have reached out and said, oh, we would love to do a voucher system with the ministry on, on a lower cost version of immunohistochemistry. So that's another model to do that. The third model, I think, is looking at alternative testing, as you're suggesting. For example, the breast strat4 cartridge from Cepheid does ERPR HER2 Ki67 for breast cancer, and you don't need to do immunohistochemistry. It's not yet FDA approved and available, but it will be very shortly. And if your lab is predominantly doing breast immunohistochemistry, which many of you are, that's a great alternative. It's lower cost, it's faster, it's much easier to do than immunohistochemistry, because immunohistochemistry has so many moving parts, whereas the Cepheid is just a single cartridge. So that's another approach. But I'll let Ashatu comment. Ashatu, what are you thinking about immunohistochemistry?
Yeah, perfect, Dr. Dine. I mean, in terms of infrastructure, in terms of high cost associated with the immunohistochemistry, I'm just repeated what you said, because I mean, in developing country, you don't have very good resources to have it in every pathology lab. So if you have like one referral or specialized with full equipped immunohistochemistry reagent in machine, so the other lab can connect with that, and then we can really look that part, because it's very obvious that we cannot even afford it. So that could be one way out to reach and then connecting the other labs. Yeah, that.
Thank you. All right. So any other questions or comments from the audience? This has been, I think, really great. Thank you so much for your questions. If you just have a comment, you can just put it in the chat. If you have a question, you can put it in the Q&A. I think we'll give it just a few more minutes to see if anyone is interested in answering. All right, so great. Here was one from Gilbert. Oh, here's some more. Okay, here we go. So Gilbert, the challenge on IHC is the acquisition of reagents. We had a limited number of vendors who happen to set their prices to their likings. Thank you, Gilbert. So I will tell you that I was just at the World Cancer Congress in Geneva, and I had this conversation directly with Roche many times. I'm having this conversation with Roche again next week. As some of you may know, several years ago, ASCP had a grant from Novartis to work with Roche on immunohistochemistry in 7 sites in 5 countries. We wrote that up as a business model for each site, which we shared with them, and then we wrote an overall business plan. Roche has finally asked for that business plan, and we shared it with them this week, so 3 years later, because they're starting to take seriously the fact that they recognize that the business case for immunohistochemistry in Africa is flawed, right? Their reagents are too expensive. The patients can't afford them. You know, we're not able to use subsidization because we don't have a model for it. So there's a lot of activity happening in the background with Roche and with Sakura Finentech, who's the other distributor of automated immunohistochemistry in Africa, on how to do that. Part of the challenge, as I'm sure Gilbert and others will agree, is that the standard manual immunohistochemistry has too many moving parts, right? You've got too many reagents that you need to get that done. If one reagent expires or one reagent runs out or stocks out, you can't do the test anymore, right? You can't make it up. You gotta have all those reagents. And so the promise of automated immunohistochemistry, of course, is that everything is in the kit. And so as long as you have kits, you can run that antibody, even though there are still some other reagents that you need. So I do think it's a labor-intensive process. It's costly. It has a lot of moving parts, and at least Roche and Sakura are now starting to step back and ask the question: how can we actually make this work? Right? They've invested in trying to have a business model, but they can't just sell to private labs, right? And private labs are honestly not buying enough because it's too expensive. So they are trying to rethink how to do this. So hopefully there will be some change in that regard. So thank you for that question. And then TechnoSpark4 again says, we frequently encounter difficult cases and fail to reach consensus. Is there a way out to communicate blocks for deciding on the answer? Yes, so that is the telepathology consultation concept. There are a couple of ways you can approach that. So one is to send the whole block to another laboratory. That could be another laboratory in your country. It could be another laboratory in an adjacent country. It could be to a laboratory in Europe or the US. That takes time because of the post. It takes money to send it. And if you don't have a good relationship with that lab, they may want you to pay for that out of pocket. So you can do that. And there are many labs in the US, for example, that do this for labs in Africa for free, but it can take 4 to 6 weeks to get a result because of just the post and, that sort of stuff. So it's not very efficient. The second approach is to have some sort of digital imaging system in your laboratory. And as I mentioned, that can be as inexpensive as about $30. You can get an iPhone or a smartphone mount for your phone that mounts right onto your microscope, and it adjusts, and you can take really beautiful pictures and upload those directly via your phone to someone else on WhatsApp or via email, et cetera. And they can look at those and give you feedback right away. That's pretty cheap. It's very low cost. Most pathologists in the US and Europe are happy to look at an image and give you some feedback on it. The challenge with that is continuity. What if you send them the case and then you forget who the patient is? Or what if you don't have the case number documented in this exchange, and then like it's a week later and you can't remember which case it is, and you had 2 similar cases, and so you can mess that up. So there's a documentation problem with just sharing images that way. So we recommend using iPath, which is a system that allows you just to share straightforward JPEG images. ASCP maintains a relationship with iPath so that we can have up to 10 accounts, and we only have 2 or 3. So we have some room in that relationship for new accounts for labs, and just allows you to share images with pathologists and for them to give you feedback on them. And then the up end of that is full telepathology with whole site imaging, but there are a lot of options in between that can cost, $3,000, $10,000, $15,000, $40,000. And those are not things I would expect you to do on your own, but those are things you can do in collaboration with funders and grant organizations, et cetera. And then Louis says, can you please advise on the collaboration with Roche? Yeah, so what we're trying to do with Roche is, so Paul Chiwesa, who is from Africa, who works on this for Roche, is trying to make the business case for immunohistochemistry in Africa, meaning not just for private labs who ask for it. Rather, how do we create a marketing plan for government labs, for all labs in Africa that need immunohistochemistry, which they all do, that is reasonable for their budgets, And I think that's he's working on it. He's fighting an uphill battle within Roche, but we'll see how it goes. And we are continuing to advise him and meet with him and give him our experience and share the challenges that you've all had. As I said, we have 7 labs that we've completely modeled out down to the penny on what it costs for them to do this work, so for them to look at and really understand the challenges that you have. So hopefully we'll be able to move this forward. And Sakura has done the opposite. They just solved the problem by creating room temperature reagents that are single test assays. So if you need to order 5 CD5 or CD30 assays from Sakura, because you're only going to use 5 in a year, they'll sell you just 5. They don't, you don't have to buy a kit of 50 or a kit of 250. They have them individually done, and they will place instruments for free. Both Roche and Sakura will place instruments for free in your laboratories, but you have to have a threshold number of tests you're buying per year. And that is also quite high. The number of tests needed to buy is quite high for most labs. And so that continues to be a challenge that we are working on with them. So we're thinking about regionalizing it. Can 10 labs that need immunohistochemistry in one country work together to meet that threshold, et cetera. Okay, great, thank you. Yeah, and Louis made a comment about core needle biopsies. So I think ultrasound guided biopsies and core needle biopsies are great for the pathologist and for the patient. It's a much better, and for the clinician, it's much easier to obtain the tissue. The tissue processing is better. The histology can be better. The turnaround time can be better. The challenge is the needles. The core needles are quite expensive, and my colleague, several colleagues of mine are working on reducing the cost of core needles at the manufacturer level. Right now, you probably know those needles cost between $50 and $75, and they're one-time use needles, and that's really prohibitively expensive. And so how to make those needles affordable is one of the things that will we'll get this to a point where it's much more reasonable. Twidros said, hi again, Blackline Hospital used to send images for iPath to second opinion, but now it's not working anymore. I don't know the exact reason. How can we resume iPath network, or if you can suggest an alternative? So great, thanks for that question. Twidros, if you follow up with Ishetu, Ishetu, if you can put your email address in the chat or in the question is, I'm not sure how to share it, but maybe you can just pull it up on the screen. If you can reach out to Ishetu, we can work with you, Twidros, to get that up and running again. Usually it's a password reset, or it may be some other issue. But go ahead, Ishetu.
Yeah, perfect. I mean, we had a discussion with Dr. Dagnato. He has some problem with that, but we'll come with you to solve it very soon. Yeah.
Yeah, definitely. Okay, let's see. Let me see if I don't want to miss anybody. Great. I have Teddy. Can you see his email, Ishetu, in the Q&A?
Yeah, I've seen. Yeah.
Can you grab that?
Yeah.
Thank you. And the same for Louis. Can you grab Louis's email? Thank you. And Ishetu put his in there too. Okay. Any last questions? I'm going to grab those too. All right. So what we will do is we will take the recording of this session. We will send it to all of you in the same email chain that you got previously. We may have some follow-up questions, survey questions. If you want to answer those, please feel free to do that. And then let me pull up the next session. Give me 1 second, because I want to make sure I'm telling you correctly. Okay. Sorry, I thought I had this pulled up and I dropped it. I apologize. So the next session will be on November 30th. And that will be at the same time for all of you in Africa, but it will be at 6:30 a.m. for Pacific time for us in the US, because we have our time change. Daylight savings time is going to kick in before our next one. So it'll be the exact same time for you in Africa, no time change. It'll be a bit earlier for us in the US. And that's going to be an AfricaCalls cytology session. So similar to this session, but it will be a didactic on cytology. So hopefully you'll join us for that. And then our last one of the year will be December 21st, which I know is right before the holidays. I'm not sure all of you will join, but we'll be there. And that will be a cytology echo, where we have a small didactic and 2 case presentations. So thank you all so much for joining us today. Please feel free to reply to the invitation email if you have any questions or comments about the series. If you want to give a talk, if you want to recommend someone to speak, if you want to present a case during one of the echoes, please do use that reply to me to let me know that, and I will put you on the schedule. And with that, I think we will conclude. And thank you so much, Ishetu, for organizing and presenting this today.
Yeah, maybe one questions, not question, but comment. We need to have this contact, because we need to start the networking and discussion follow up. So how do you manage that one, Dr. Jan?
That's a great question, Ishetu. So what we can do is if you want to develop a document to share with the group on this topic, which is, a series of questions or information that you want people to have, whatever you want to share, I can send it out through this invite list for the meeting. And then what I would suggest is that we have a link in that email that allows people to go and sign on to a third party. So for example, a Google Sheet or a Google form where people can sign on with their name and information that they want to participate and be part of it. And then you can have a sub-working list of people who want to work on it with you.
Perfect. Thank you. Okay.
Messentola had one last question. What is the stand of ACP in supporting private pathology laboratories in resource-limited countries? Thank you. That's a great question. So We are always available to any laboratorians and pathologists for advice, for resources, for information. What we can't do for private labs is provide them any funding from ASCP for, reagent supplies or equipment. We can help them reach out to our vendors for our vendor negotiated pricing on different things that we have. And we can also make connections for those labs to anybody in the US that they're trying to reach out to. But in general, the big stipulations, we can't use our membership dollars, which come from our members, to fund work in private labs. But other than that, we can work with them and help them to do stuff. All right, so I think I'm just going to capture two things, and then we'll be able to close it out. Sorry. Okay, thanks everyone so much. And again, we will see you on November 30th and hope you are all well.
Okay.